Possibly the most important vestibular test. What do you think it is? I personally think it is a hearing test. Um, they're so simple. You can get them anywhere. They're very cheap and they are so meaningful and they tell us so much. But I don't know if a lot of PTs know how to read hearing tests or understand them or what it tells us and how diagnostically important they are. So we're going to go through hearing tests and how to read one and what it means for us and how it tells us and whatnot. So here is just an example of literature that came out. So these are all of the different vestibular tests that individuals can do, right? Like you have a hearing test, you have the VHIT, you have OVEMS, CVEMS, you have caloric testing. And what it's telling you in this particular figure is how helpful that is diagnostically or what it tells you. And based on these observations, it's really not helpful diagnostically other than the hearing test when it comes to Meniere's disease. So you can see some people have high frequency loss. This particular one is also helpful. But you can see like in the caloric testing, 38% tested normal, 61 asymmetric, which is like practically 50-50. So do calorics really help us? The CVEMS are where most people were normal with Meniere's disease. And here again, a lot of people were normal. OVEMS had some more diagnostic criteria, but what was most helpful was actually the audiogram or the hearing test and the VHIT, but I think a lot of ENTs don't do VHITs. So let's go here. How do we read a hearing test? So first we want to look at the actual decibels on the side and how well they're hearing. So in this particular situation, 0 is good. So we want people to be between -10 and 25. So we want them to ride this line at the top. Mild hearing loss starts at 26. So once they hit like down here, we're starting to enter into this mild hearing loss. So that's the first thing to be aware of. So on that spectrum, we also have frequency at the top. So here at 125 is a low frequency, all the way up here to 8,000 is a high frequency. So a lot of us have heard of like sensory neuronal hearing loss, high frequency versus low frequency. You're going to see that on this particular graph. So there's two different types of hearing that are tested on hearing tests. There's bone conduction hearing and there's sensory neuronal hearing. Bone conduction is where they do an oscillatory sound through the actual bone, seeing if the outer and middle ear are preventing sound from reaching the inner ear. And then sensory neuronal hearing loss is actually damage to what is typically what we're concerned about, which is damage to the cochlea, the auditory nerve, or the hair cells. So that can present with high frequency or low frequency. In Meniere's disease, what we actually see is low frequency hearing loss. A lot of our other diagnoses, like acoustic neuroma, labyrinthitis, these are going to, aging is going to result in a high frequency hearing loss. So that's really helpful from a Meniere standpoint. You're going to see this kind of characteristic low frequency hearing loss that we typically don't see. So when you're looking at this hearing test, you can see what is bone conduction versus air conduction. Your bone conduction are going to be these brackets versus your air conduction, which is going to be either the circles and the X's and then the ear laterality. So what you're going to do when you look here, so this one's nice because it's color coded for you. So red is your right ear. So this would be an example of high frequency hearing loss, right? So we have our low frequency starting around 0, looks good, but we have bilateral low hearing loss as the frequency increases. And right and left are both impaired. They're both downsloping. We want to see a straight line. We don't want to see an upslope. We don't want to see a downslope. And this is just showing us that they tested both bone conduction and air, and they're both abnormal. Masked versus unmasked is when with masked, they will do like a white noise in the other ear so that they can get laterality in that bone conduction. So they'll try and stimulate the side they're testing and put a white noise in the other ear so that they try and just isolate that side of the that particular ear when testing. That's what that is, it means. Okay, so age-related hearing loss we typically see like this. We have a high frequency hearing loss. It's not sudden, it happens slowly over time, and it's symmetrical on both sides. So this would not, although unfortunate, would not be a cause for concern for us, and this would just be hopefully someone who would get help with hearing aids. So at hearing test in Meniere's disease, we see this upslope. So this right here is your right side. You're gonna, because it's a right-sided loss, you're gonna have an abnormal in both bone conduction and sensory neuronal. And you see this upslope unilaterally. And then high frequency is normal. So this would be what you're looking for on a hearing test when you're trying to see is there Meniere's disease. If this is a new patient who's had maybe one or two attacks, they probably won't have a hearing loss. We don't typically see these low frequency hearing losses until, the disease has had time to attack over a series of years. So individuals with chronic dizziness do benefit from annual hearing tests just to give us an idea on how this is playing out. From an acoustic neuroma, you will see, again, unilateral high frequency hearing loss. Typically, these are going to be a sudden onset, right? And then this is also potentially what you could see with a labyrinthitis. Okay, so acoustic neuroma, I just showed you. A labyrinthitis is going to be a sudden loss of over 2000 hertz. And so right here is right where you see this is very similar for an acoustic neuroma, but right around here, this end slope is going to also be consistent with labyrinthitis. So that is what a hearing test can show you and tell you, and now you know how to read one.